He is maintaining 88. No.
He was always bad. He was always bad. And what about his echo? This Jelko shouting. Out.
Saturation check करो. Probe लगाओ. Probe. नहीं, but he is a chronic retainer. His ABG is showing 58. ABG देख के मैंने देखा था उसका 90. He is not a known case.
In diabetic, maybe saroglitazole, APR combination. There is logic in it, but we don't have data. Now coming to the other extreme, a cirrhotic patient, NASH cirrhosis, all the other causes ruled out.
क्वेश्चन खत्म हो जाए.
Wait for some time, session.
We'll start dot on time. 10:15 है, 11 we could start.
आगे तो सर भी है।
Good morning, everybody. Great to be here with all of you today. I'm Dr. Shashank Akerkar. I'm the Secretary of Maharashtra Rheumatology Association. Way back, another 20 years back, when I was a MD student, I really didn't have access to much of rheumatology teaching or patients. This is to some extent possibly existent today as well, because we do have a shortage of rheumatologists. This is not just for Maharashtra, India, it's a global problem. We do have a shortage of rheumatologists. Now, being on the other side of the chair, all of us at Maharashtra Rheumatology Association decided that we should be taking this teaching right to the PG students, that whoever is there, to each and everyone across Maharashtra and for that matter, the whole of India. So that is why we are starting with PG sessions. These would be online sessions on every second and fourth Sunday, every month, starting from 11 a.m. to 12 p.m. Today, we would be having the first session. Let me welcome and introduce Dr. Varsha Bagul. She is a senior consultant rheumatologist attached to Bombay Hospital and MGM Hospital, Navi Mumbai. She was the professor in medicine attached to JJ Group of Hospitals and Medical College. Welcome, madam. And today, let's have a look at how do we go about history taking as far as rheumatology cases are concerned. We would be starting with basic clinical things to begin with, and then down the line we would move ahead with specific topics like rheumatoid arthritis, including spondyloarthropathy as well. A few housekeeping rules. Can all of you put yourself on mute so that there is no disturbance in the background? I'm still hearing quite a few sounds in the background. Please put yourself on mute. And secondly, any questions? See, after the lecture, we have kept almost 20 minutes purely for the question and answers. This is going to be a proper interactive session, not a didactic, not a one-way sort of a lecture. So we have 20 minutes at the end. Whatever questions you have, you keep putting it on the chat. We will definitely answer them after the session is over. Thank you. Let's start. Dr. Varsha, Bagul madam, over to you.
Good morning, everybody. A warm welcome to all of you. Actually, when we started, we gave a thought. We spoke to the head of the departments of medicine of all the colleges, and we found them to be very enthusiastic. And I hope the sessions will help you. And we expect a lot of enthusiasm on the part of the postgraduate also, because that is what will keep us going and continue this series in a better way. Yeah, so I'll first start with this paragraph. Shashank, should we start?
Yeah. Madam, you're sharing your screen is not being shared. Share your screen.
Screen is not seen? Just a second.
जबलपुर में हड़ताल होने लगेगी ना समझ आना
Starting at ₹99 only. To download the app, give a missed call on. Request to all of you, please. Please mute your speaker.
Is it okay?
Yes. Go ahead.
Okay. Yeah. So I start with medicine. A lot of disturbance in the background. which goes like this. No greater opportunity, responsibility, or obligation can fall to the lot of human beings than to become a physician. In the care of the suffering, the physician needs technical skill, scientific knowledge, and human understanding. The patient needs. Can everybody please put the mobiles on mute? There's a lot of disturbance. Shashank, can we mute everybody? Shashank?
Hello, Dr. Bagul, can you start?
Yes, sir.
Dr. Varsha Bagul. Madam, can you start now? Yeah. Madam, you'll have to unmute yourself.
I'm already unmute. Not able to hear me?
Was not able to hear you. Now you can start and share the screen again. The screen
Okay.
sharing has again got disabled.
Yeah. So I start with the first paragraph from Harrison's textbook of medicine, which goes like this. No greater opportunity, responsibility, or obligation can fall to the lot of human being than to become a physician. In the care of the suffering, the physician needs technical skill, scientific knowledge, and human understanding. Tact, sympathy, and understanding are expected of the physician, for the patient is no mere collection of symptoms, signs, disordered functions, damaged organs, and disturbed emotions. The patient is human, fearful, and hopeful, seeking relief, help, and reassurance. So I want postgraduates to remember this, that the patient is not just a collection of symptoms and signs. There's much more to it. And the patients come with a lot of expectations from us. And we, as physicians, need to give them that time and, uh, and advise them accordingly. So, history taking in rheumatology is the most important skill needed for proper handling of a patient with a rheumatological complaint. Obtaining a good history will help to reach almost 90% of the diagnosis. However, history taking is mostly dependent on experience and practice rather than a theoretical recall. I mean, we cannot just remember, oh, this patient I have to ask this. No, as you keep on asking questions, keep on taking the history, you can add on, and eventually it becomes more of an experience and practice. Here we now discuss the most important points in history taking patient. The approach starts as we start in history taking with all our patients, but since a good number of patients would have musculoskeletal complaints to begin with, we focus more on the joint pains, the pattern, symmetry of joint involved, number of joint involved, the other constitutional symptoms, and a rheumatological review of systems.
Madam, sorry to interrupt.
Rheumatological disease
Your screen is somehow got disabled again. The sharing has got
not visible.
mm-hmm. Got disabled again.
Shashank, do you have the slides? Can you put the slides on?
Now is it visible?
Well, Varsha.
Is it visible now?
Yeah, Varsha, it's visible.
Okay. Yeah. So rheumatic diseases are all systemic diseases affecting all body systems with no system that is preserved. For example, you can have a patient coming with neurological symptoms like a stroke because of a ischemic stroke, and can eventually land up to have a diagnosis of systemic lupus with secondary antiphospholipid antibody syndrome. So here the initial presentation was not joint pains, but yet the final diagnosis was rheumatological. This concept emphasizes the point that good foundation in internal medicine is essential to take a good for a good rheumatology practice. Only a good internist can be a good rheumatologist. So here, when we go to our objectives, is to the objectives would be to compose a comprehensive and organized history for patient with rheumatoid arthritis, including symptoms, treatment, diagnosis, and treatment So what I did is I took patients as they come to the OPD, the presenting symptom, and then we take it from there. So the first case is a 30-year-old female who comes with history of pain, swelling, stiffness of small joints of both hands and feet, bilateral wrist, bilateral shoulder, right knee, and left ankle. So this is clearly a young female who is coming with polyarthritis. Now, whenever we deal with a patient with joint pains, we start with the onset. It is important to understand whether the onset was sudden or gradual. In case of a sudden onset joint pain, if we could think, besides trauma, it could be a
Screen
septic
sharing is
arthritis.
gone again. Your screen sharing is again.
Come again?
Yeah, can't see your screen.
Is it visible now?
Now it's visible. Yes.
Yeah. So, coming to the onset of joint pain. So, it is essential to know whether it's a sudden onset of joint pains. The causes which be around few years, I mean, few hours to a few days. And here the diagnosis would vary from it being a septic arthritis to a crystal-induced arthropathy, could be trauma related. You could really sometimes have patients of acute rheumatic fever coming with sudden onset of joint pains. You can also have an elderly onset rheumatoid coming for the first time at age of 75 and 80, coming as an acute onset of inflammatory arthritis, and reactive arthritis could sometimes present with a sudden onset of joint pains. The second is gradual. Now, gradual onset of joint pains going from few weeks to months would be very classical symptoms in rheumatoid arthritis, systemic lupus, psoriatic arthritis, reactive arthritis, juvenile induced arthritis, and degenerative arthritis like osteoarthritis. The second aspect of the joint pains is to know the duration, whether the duration was less than 6 weeks or it is more than 6 weeks. Now, this 6 weeks is very important because sometimes you can have post-viral arthritis, especially the parvovirus B19 affecting the joint pains and classical causing symptoms like rheumatoid. But these would remit in less than 6 weeks, whereas a duration of more than 6 weeks would point towards this going on to be a rheumatoid arthritis. Now we go to the patterns of joint affected. Now we need to know which joints are more commonly affected and which diseases. Like if there's a symmetrical polyarticular joint pain, small joints predominantly involved, it will be rheumatoid, lupus, psoriatic arthritis, you could have polyarticular gout, and reactive arthritis. DIP joints are classically involved in psoriatic arthritis and osteoarthritis. The bony swellings of the DIP, PIP, and first carpometacarpal joints are also very classical of osteoarthritis. When you have a patient complaining of proximal girdle joints being involved, like severe pain while getting up in the morning, not able to raise the arm above the shoulder, or not able to get up from bed, would be a symptom of polymyalgia rheumatica. Also, rheumatoid arthritis can have proximal girdle joint involvement. Asymmetrical large joint oligoarticular disease could be again psoriatic arthritis, rheumatoid arthritis, ankylosing spondylitis. And acute monoarticular disease can be because of tuberculosis, Chronic monoarticular, again, tuberculosis is one of the important differential. When you have an axial joint involvement, along with sacroiliac and girdle joints, then we think of ankylosing spondylitis first, followed by psoriatic arthritis, reactive arthritis. Only axial joints would be lumbar and cervical spondylosis. Again, osteoarthritis could present, and you could have dactylitis, that is inflammation of the entire digit, which is very classical of psoriatic arthritis.
The screen is again disabled. Screen sharing is again disabled.
Shashank, shall I tell Shivani to share with you?
Yeah, I think that will be better. Mumbai Arthritis Clinic at gmail.com or WhatsApp to me. I'll share it from my end.
WhatsApp.
But you can continue. I will just do it and share it from my end.
It's getting disconnected. Got the slides?
Yes, I'll just share. Just give me 2 minutes. I'll share it from my end. Can everybody see the screen, the slides?
Yes, Shashank.
Yeah, please go ahead, madam.
Yeah. Next. This one. Yeah. Go back to the previous slide. No, the previous one. Okay. So coming to the symmetry of joints. So coming to symmetry, patients with rheumatoid arthritis and SLE would have more asymmetrical joint involvement. Patients with psoriatic arthritis, reactive arthritis, spondyloarthropathies would have an asymmetrical joint involvement. Then coming to the number of joints involved. Yeah, so this is a classical picture depicting the joint involvement. The first patient is a case of, the first picture is about rheumatoid arthritis, where you can see symmetrical MCP and PIP joint involvement, bilateral wrist involvement, bilateral MTP joint involvement, right shoulder, and the right TM joint. Again, TM joint is a very important joint, which, I mean, it's a very diagnostic involvement in patients of rheumatoid arthritis. Like you already have a spondyloarthropathy having a TM joint involvement, a psoriatic arthritis having a TM joint involvement. The second picture is about reactive arthritis, where you're seeing a right sacroiliac joint involvement, a right knee joint involvement, and left ankle involvement. So this group of diseases predominantly most commonly affects joints of the lower limb, and it's basically an oligoarticular involvement, and the major joints are predominantly involved. The third case picture is about a patient of ankylosing spondylitis, where you can classically see the axial involvement, inflammation in the neck, the dorsal-lumbar back, bilateral sacroiliac joints, and the right knee. So bilateral sacroiliac joint involvement is a hallmark of spondyloarthropathies. The fourth picture is about psoriatic arthritis, where you're seeing the DIP joint involvement. So the DIP joints are classically involved in psoriatic arthritis and osteoarthritis. Rheumatoid, you will never see the DIP joint being involved. But you're also seeing the involvement of the left wrist and the right sacroiliac joint. And then the inflammatory OA of the hand, where you are again seeing the DIP joint involvement. Okay, next slide. Yeah. So once we have seen the symmetry of the joints, the number of joint involved, we also look for associated symptoms like redness, swelling, and morning stiffness. So the morning stiffness is a most important symptom. I think we should give time to actually find out the amount. Yeah. So we need to find out the amount of time the patient takes from getting up from bed to getting back to his normal activities, which in a patient with inflammatory arthritis would be for more than an hour. There'd be a significant fatigue which would be involved. Activity improves symptoms, so that's the most important thing. Once the patients get back to doing their activities, they feel much better. Rest would worsen the symptoms. Systemic involvement is very common with inflammatory arthritis, and these joint pains respond well to corticosteroids. Whereas in a mechanical pain, the stiffness will be there. Like sometimes you have patients complaining of pain in the knee joint. This could be an osteoarthritis, but at night when the patient goes to sleep, the knee also tends to get locked. But it would not take 1 hour to come back to normal. So it would be less than or equal to 30 minutes. They'll have minimal fatigue. Activity will worsen their symptoms, whereas rest would improve their symptoms. And you would never see any systemic involvement, and these joint pains would never respond to corticosteroids. Next slide. So now we have this young female who has come with inflammatory polyarthritis. So here we know that our working diagnosis would be rheumatoid arthritis. So what are the questions that we would ask this patient? One is whether there is any history of fever. Now, fever, generally patients with rheumatoid arthritis could have fever coming with whenever there's a flare or whenever the joint pains are too bad, they feel little feverish, but you would not get that moderate to high grade fever, witches and rigors and all that in a patient of rheumatoid. We also look for systemic complaints like weight loss, fatigue, loss of appetite, night sweats, generalized malaise. Then patients with rheumatoid arthritis could have ocular involvement in the form of scleritis or episcleritis, but this would come much later in the course of the disease, as against patients in where the ocular involvement could be a presenting symptoms. Patients over a period of time in rheumatoid arthritis, say about 4, 5, 6 years down the line, could develop dry eyes because of secondary Sjogren's syndrome. Rheumatoid patients are prone to pulmonary manifestations like interstitial lung disease. They could have persistent cough, breathlessness, and chest pain. So we should ask for these questions also. Rarely you can have a patient of rheumatoid arthritis coming like an acute pneumonia, and this could be methotrexate induced. So here we should keep this diagnosis also, this aspect also in mind. Patients with long-standing rheumatoid arthritis could have vasculitic lesions, could have neuropathic symptoms. History of smoking is very important because that predisposes to rheumatoid arthritis. And we should also ask for history of alcohol consumption, as we would be starting the patient on disease-modifying anti-rheumatoid drugs like methotrexate. So whenever you have a patient with suspected RA, you would look at all the systemic complaints. Next slide. So here we come to the second case. This patient is a 32-year-old male patient who comes with history of severe pain in the left buttock, radiating to the thighs, with history of lower backache and severe pain in the left heel. Now, buttock pain is a very classical symptom of patients presenting with spondyloarthropathies. Now, you will never see a patient of rheumatoid having buttock pain like a sacroiliac joint pain or heel pain or a low back pain. So these are classical features which differentiate between rheumatoid and spondyloarthropathies. So this buttock pain occurs because because of sacroiliac joint involvement. Now the target um, um, uh, inflammation in rheumatoid arthritis is the synovium. Hence, we do not see backache, sacroiliac joint pain, or heel pain in the rheumatoid arthritis. The target is the enthesis. So here we see patient having buttock pain. Now sometimes patient would complain of pain on one side, but when you go into the history, they can always recollect, yes, few months back I did have a similar kind of pain on the opposite side. Sometimes patient may have pain only in one joint, but when you further investigate and go for an MRI, you can see involvement on both the joints. So bilateral sacroiliac joint involvement is a diagnostic criteria for spondyloarthropathy. Whenever you have a unilateral sacroiliac joint pain and the patient is very clear that there's no history of pain on the right side, any on the opposite side anytime in the past, then this sacroiliac, and if the patient did not have the other features like the heel pain or the low back pain, then yes, tuberculosis would be the first thing. It could be a tuberculous sacroiliitis. Coming to the heel pain is also a part of enthesial involvement and the low backache. Now, this low backache is the patients have so much of pain. Like if you go detail into the history, patient will have severe morning stiffness. Patient will not be able to get up from bed. Even this pain classically starts at around 2-3 a.m. in the morning, and we realize that the patient is not able to even turn. So if you ask the patient, "Are you able to turn from one side to the other side?" and the patient will say they have marked difficulty in doing so. This low back pain also gets aggravated on sneezing and coughing. So this is a patient with a left sacroiliitis, with a left enthesial pain in the heel and a low back inflammatory backache. Next slide. Next slide. Shashank, can we go to the next slide? Shashank?
I've already shifted to the next slide. Can you see it? Inflammation. The next one,
Yeah. Next slide.
that will
Yeah.
be case 3 then. Yeah.
Yes. The previous one. Next. No. Previous. Prior to this. Yeah. So these are the features what would differentiate between a inflammatory low backache and a mechanical backache. Once we go through these points, it will be very easy to come to a diagnosis. Like an inflammatory low backache would start at a younger age, would be insidious in onset. The duration classically would be more than 3 months. The morning stiffness is more than 60 minutes. There's a nocturnal pain. As I told you, patients get up at 2 a.m. and 3 a.m. in the morning with severe pain, and they feel much better after getting up after about half an hour, 1 hour. They gradually start becoming better. They could have on examination, they would have sacroiliac joint tenderness. And here we have to remember that the mobility of the spine is restricted in all the planes. The chest expansion is also decreased decreased because of involvement of the costochondral joints, and they do not have any neurological deficits. So these patients would not complain of any tingling, numbness, or sensory symptoms, or the pain radiating to the foot, which would be classically seen in a mechanical low backache. So mechanical lower backache can occur at any age. It is actually more often acute in onset. The symptom duration is less than 4 weeks. The morning stiffness is never more than 30 minutes. Nocturnal pain would be absent, and exercise would exacerbate the pain, and they would never have sacroiliac joint involvement, and the back mobility is only restricted as far as the flexion is concerned. Chest expansion would be normal, and there could be possible neurological deficits. So once we come to know that yes, this is an inflammatory backache, the battery of investigations approach on clinical examination would change. For a mechanical backache, the approach would be different. Next slide, Shashank. Yeah. So now suppose like this patient, this we are suspecting spondyloarthritis because of the actual involvement, because of the sacroiliac joint involvement and the enthesial involvement. So whenever we encounter a patient with spondyloarthropathy, it is very important to ask for history of uveitis. So any history of patient having pain, redness, and photophobia and visual drop in the visual acuity is very classical of uveitis. And sometimes patients may have had previous episodes and may not know that this is connected with the backache and would not voluntarily give that history. So we need to go into the details of that. It's very important to ask for history of psoriasis. See, if it is an evident psoriasis, it will be clinically obvious. But subtle psoriatic lesions, like patients may not know also that they're having these having psoriasis, like dandruff, scaly this thing, or subtle lesions behind the ear or in the periumbilical area. These are the things which can be easier over the extensor tendons, over the elbow. So these are lesions which may get missed out, and we need to ask for this history. Then, of course, history of infections like gastroenteritis, sexually transmitted diseases, tonsillitis, all these could present as reactive arthritis and give rise to a similar kind of clinical picture. Then history of inflammatory bowel disease, like we have ulcerative colitis, patients having loose motions with severe abdominal pain and passing blood and mucus in stools, and this could also contribute to a spondyloarthropathy. Details of inflammatory back pain we have already discussed. Now, classically, as against rheumatoid arthritis, patients with spondyloarthropathy would have predominantly lower limb joint involvement, major joint involvement, as compared to rheumatoid arthritis, where we classically see upper limb joint involvements and small joint involvements. Plantar fasciitis is also very important, a heel pain. This plantar fasciitis, sometimes we tend to take it very lightly, but it can be so bad that patients are just not able to walk. I mean, I have had patients who have received biologics only for the enthesitis. It's very difficult to treat at time, and patients can be in severe pain. So this is what we would look for when we are suspecting a patient of spondyloarthropathy. Next slide. Yeah, so now this is the third patient. This is a 25-year-old female, recently married, who comes with 2 months history of fever, joint pains, loss of appetite, hair loss, and malarash. So here the presenting symptom is fever, which would not be in a patient of rheumatoid. Rheumatoid would start with joint inflammation, joint pains. So this is fever, which has been moderate to high grade, occasionally with chills. A lot of systemic features like loss of appetite, hair loss, malarash, and this patient has joint pain. So this is a general polyarthralgia. The striking difference between arthritis of lupus and arthritis of rheumatoid is that lupus basically is a non-erosive arthropathy. So you rarely see a patient of lupus having deformities, which in a patient of untreated RA, within 3 months, they would gradually start showing the ulnar deviation, and the deformities can come very fast depending on the activity of the disease. Now, hair loss in patients with lupus, if there's a diffuse hair loss, yes, it could be a sign of active disease, and this is generally reversible after the disease is come under control. But occasionally in patients with discoid lupus, they can have patchy hair loss, and this is irreversible. Hair loss sometimes can be because of therapy also, like we use cyclophosphamide for treatment of lupus nephritis, and this also is irreversible. Coming to the malar rash. The malar rash is a very classical erythematous rash, sometimes with papules or plaques, and it goes over the bridge of the nose, but classically spares the nasolabial fold. Okay, and loss of appetite is a systemic feature of the disease, saying that this is a systemic disease with complaints going on for quite some time. Next slide. So when we suspect lupus, we would ask for following symptoms. We should ask for hair loss. Sometimes the patient may not volunteer the history. Then look for the malar rash. Now, mouth ulcers. Generally, when we talk about mouth ulcers in the patients of lupus, yeah. Coming to the mouth ulcers. Now, in a patient of lupus, we should always look for palatal ulcers. Sometimes they are missed. So when we examine also, we should look at the palate, and you may see a large erythematous ulcer over there. And this also correlates with the activity of the disease. Then photosensitivity is again very classical for these patients. In patients with in patients of lupus, along with the malar rash, there can be an erythematous rash which is seen all over the body on the sun exposed areas, so on the arms, on the legs, on the neck, and this also could be a sign of active disease. Now, discoid lesions are also common in patients with systemic in lupus, which is also called as discoid LE. And these are coin-shaped lesions which are seen mostly around the ear or on the face or on the extensor tendons. And these lesions generally tend to get inflamed, they can ulcerate, and they scar. They would leave behind a scar, which is not seen with the Mahler rash. So this is it leads to a scar. Then coming to the Raynaud's phenomena. Raynaud's phenomena is also could be a presenting manifestation of patient with lupus. But whenever I see with a patient with a Raynaud's phenomena, we should always think probably this is not only lupus. This could be a combination of a sort of a mixed connective tissue disease type of a. And what is this Raynaud's phenomena? This is a vasospastic disorder. On exposure to extreme cold, the patients have become absolutely white, then they can become blue, and then the erythema sets in. So it's white, blue, and then red. Now, Raynaud's phenomena sometimes can be very painful, and at times we have seen patients getting bad digital ulcers and digital vasculitis because of Raynaud's phenomena. Presence of Raynaud's phenomena also tells us that the disease is quite active, and patients who have Raynaud's phenomena are more likely to develop lung involvement and renal and cardiac involvement. Now, pleuritic chest pain, patients with lupus can have polyserositis, wherein they can have a pleuritic chest pain, they can have pleural effusion, ascites. So, polyserositis is one of the clinical features of systemic lupus. Coming to headache, sometimes intractable headache can be a presenting symptom, and this could be like a sort of a marker that probably this patient would be having a CNS lupus. Hematuria is of course not a symptom, but when we examining and go for investigations, we always do a routine examination. Sometimes they can have puffiness of face, edema of the feet and face, and this could be sort of early lupus nephritis going into nephrotic syndrome. And coming to the history of psychosis, these patients can have episodes where they are completely irrelevant and can have psychotic episodes. And patient might have had such a history in the past, but may not know that this is related to the present disease and may not volunteer the history. So we need to go ask about that. Patients with lupus can have generalized seizures. This could also be the presenting patient of a complaint of a patient with CNS lupus. Then coming to the vasculitis, they can have a rash, which can be erythematous rash, which is on the sun exposed areas, and urine symptoms we already discussed. Yes, coming to the obstetric history now. The obstetric history is very important in each and every patient with lupus, as the male to female ratio, the female to male ratio is 9:1. So against nine female patients would have a male patient having lupus. A detailed obstetric history, especially when we are encountering patients with lupus, is very important. Past history of abortions, patients being on oral contraceptives. These things also have a lot of impact on diagnosis. Coming to the next slide. So now here we have a patient, it's a little elderly patient, 40-year-old female who comes with 1 year history of progressive tightening of the skin. The patient says, my skin is becoming tight, and they have swollen digits, they can have oral ulcers, weight loss, and joint pain. So here you see the joint pains have come in much later. So the symptom, the presenting symptom is basically progressive tightening of the skin. And this tightening of the skin is called as sclerosis. Now, this sclerosis can be of two types. It could be a localized sclerosis or a systemic sclerosis. Localized sclerosis is actually like a morphia type of lesions which are seen on the trunk, and they are patchy plaques of thickening of the skin. Whereas a diffuse fibrosis, a systemic fibrosis is more diffuse fibrotic skin, which is proximal to the elbows and the knees. And these patients generally with progressive tightening of the skin or diffuse tightening of the skin are prone to would have symptoms of Raynaud phenomena within 1 year of the symptom onset, and they are more likely to have pulmonary, renal, and cardiac involvement. Swollen digits. These patients of previous slide. Yeah, so these patients of progressive or sclerosis, they have swollen digits. So the entire digit is swollen, and that is because of the edema over the. So they don't have you could have PIP joint involvement of MCP joint involvement. Here it is the entire digit that is swollen, and the skin is so tight that you're not able to pinch the skin over the with your fingers, and that's why these patients develop tightness of the digits more commonly than getting deformities. Then again, we look for oral ulcers, palatal ulcers. Weight loss, yes, these patients of sclerosis, systemic sclerosis, have a lot of systemic features, a gradual weight loss, and being ill for quite some time. I mean, the illness goes on for months and years together before a proper diagnosis made. Again, the joint pains are secondary to the swelling of the digits, and they can have a generalized polyarthralgia. Next slide. Yeah, so whenever we suspect a patient of systemic sclerosis, we should find out the pattern of skin tightening. Where all is the patient feeling that the skin has become tight? They're sometimes not able to open the mouth because the skin over the face is tightened. Then we should ask for history of calcinosis. Of course, this calcinosis is not a symptom, it is a sign. Generally, we look for calcinosis. So these are cutaneous deposits of basic calcium phosphate, which are seen over the hand, PIP joints, fingertips, and they can become infected, they can become ulcerated, and they discharge a chalky white material. And to tell you very frankly, these are persistent, they can be there for years together, and they are very difficult to treat. Coming to Raynaud's phenomena, as we already discussed, we should ask for history of exposure to cold and changes, or especially in women during winter when they get up in the morning. They open the tap, and that cold water can also initiate a Raynaud's phenomena. So this history is very important, and we need to guide the patients accordingly. That when they get up in the morning, they should not do work which is related to water in the morning, or they should use warm water all the time. Then coming to the history of acid reflux. So patients with systemic because of which they can have a acid reflux. And this acid reflux can be so bad that it can lead to microaspiration also. Then interstitial lung disease is very common in patients with scleroderma, and we need to be very careful about history of chronic cough, breathlessness, going for a long time, going on for quite some time, fall in the saturation when you make the patients walk, they feel very tired, and they have restriction of their daily activities. Now, patients with scleroderma can also have muscle weakness because of inflammatory myopathy. Sometimes it can be so bad that they can have elevated muscle enzymes and a polymyositis, wherein then we think that this could be a mixed connective tissue disease rather than only scleroderma. Should also ask for history of hypertension. Patients of scleroderma are prone to develop hypertension. They can have scleroderma renal crisis where the blood pressure can really shoot up very high, and that could be one of the causes of patients going into renal failure. So whenever you suspect scleroderma, we need to ask, especially stress on the skin tightening, the calcinosis, Raynaud's phenomena, the respiratory involvement. Next slide. Now this is a 50-year-old male who comes with acute onset excruciating pain, swelling, and redness in the left foot. So this is very diagnostic. I think all of you must have judged this is a patient with acute gout. So whenever you see a patient of acute, sometimes the pain, and it generally occurs at about 2 a.m., 3 a.m. in the morning, excruciating pain, the toe is like a tomato it becomes, and we should ask for history of fever, any history of similar episodes in the past, because to presentation, on presentation, it actually looks like cellulitis. So any history of similar episodes in the past, go into the details of alcohol consumption, history of renal stones, which could be because of uric acid, hypertension because of hyperuricemia, and the family history of gout. So this is a very classical patient with acute gout. Since this is a small talk, I just took and how who could go into the details of each symptom. So you start with a particular symptom. The expertise only comes when you start sitting in the OPD and see one patient after that. Sometimes in rheumatological patients, you may not be able to come to a diagnosis on day one, because rheumatological diseases are known to evolve over a period of time. And we need to be very patient, and we really need to give them time. Coming to our history taking, after the presenting complaints, onset, duration, progress, the direct questionings, we also ask for past medical history of any rheumatic disease, history like lupus, gout, psoriasis, etc. History of recent infections, then you think of reactive arthritis, history of chronic diseases like you can have an arthropathy associated with long-standing diabetes mellitus. Then the family history, if similar condition happened in the family, rheumatoid arthritis is known to run into families, psoriasis is known to run in families. So any family member suffering from psoriasis also become important. Also important for a patient with spondyloarthropathy. Like I had a family of 4 brothers, all 4 suffering from spondyloarthropathy, ankylosing spondylitis. So this history also also is very important in patients with spondyloarthropathy. We need to have a detailed medication history. Sometimes, patients complain of a lot of joint pains. And then when you examine the patient, you generally sometimes see that there is no actual synovitis that you're able to see. Now, here it is very important because the patient has to come from home to the clinic. The patients previously go to their family physician, take an intramuscular injection of NSAID or a steroid injection so that at least they can come to the clinic. So we need to ask for this history, a detailed medication, whatever patient has received, all the medications that the patient has received in the past. Sometimes patient could have been on Ayurvedic medications for a long time. We don't know whether they're containing steroids, not containing steroids. We need to have all the details. In fact, when the patient walks in, also sometimes you see the patient has got Cushing-Gerd features. Patient is complaining of a lot of joint pains, but you're not seeing any deformities, no active synovitis, then yes, this patient could be on steroids. Then all the details of the disease-modifying anti-rheumatoid drugs that the patient has received up till now, including methotrexate, hydroxychloroquine, whatever medicines they have received. The first visit actually to us has to be very comprehensive. You have to go into all the minute details, and for that, you need to give time to the patient. You have to sit with the patient, and sometimes in a busy OPD, we tend to overlook some things, but the first visit at least has to be very comprehensive, because whatever diagnosis you're going to make on day one, that diagnosis is going to go on and on. So we need to keep this in mind, and the new patient has to be given time. It's very important. I'll just tell you one example. Like I had a 40-year-old female who came with a lot of general complaints, just lack of interest, fatigue, malaise. Husband is complaining that she doesn't want to do anything. And okay, I examined her, took the history, everything normal, vitals normal. Clinical examination was actually, I could not find anything. Then when the patient sat down, I went into the menstrual history. And then she said, "Ki, madam," the husband said that she's not getting her menses. I said, "Since when?" So he said, "Since the age of 28, when we had our first daughter. She bled profusely after the delivery. And since then, she's not got menses." So here, this is postpartum hemorrhage. And this would have led to pituitary necrosis and Sheehan syndrome. So when I did her cortisol levels, they were very low. After treating that, she's back to normal. Like within 6 weeks, when she came for a follow-up, the husband was so happy. Had I not taken the menstrual history, or had not given that time at that particular on that particular day, maybe I would have missed this diagnosis. Even hypothyroidism, patients have so much of um, uh, um, like a lot of symptoms, but on examination you find features of myxedema. So these are things that we need to keep in mind. Then you can have females who come with a lot of aches and pains, neck pain, backache, everything hurts. And if you ask them for morning stiffness, yeah, you cannot get up from bed and bed. But then if you ask how much time does it take, within 4 to 5 minutes I'm able to get up. Okay, so then this is not rheumatoid. Okay, so then that early morning stiffness is so important. So you really need to give time to the patient. The first visit to the rheumatologist has to be. Sometimes we have patients who have visited many doctors and then come to us. So we have to give that time and go through all the files and see everything before we come to a tentative diagnosis. Yeah, the social history is very important. Patients married, not married, occupation, how many children do they have, whether there's any history of tuberculosis in the family, and then of course the details of smoking, alcohol, the vices, everything. So you need to go into each and every aspect of the history in detail. So this is all that I wanted to share. There are many more cases that were many more symptoms that we could have gone into details, but rheumatology is a vast subject, and it's not possible to cover in such a short time. Yeah. Any questions, Shashank?
Any questions from anybody? I don't have anything in the chat box. Anybody would like to ask anything specific? You're most welcome.
I agree, this is a very basic talk, but we thought that since we are starting with the teaching series for postgraduates, let us start with simple thing, simple diagnostic use, and then go take one disease at a time and then go into the details. So this was a little very, very basic talk. So it may sound very routine for people who have rheumatology clinics in their hospitals, but this is for students all over Maharashtra. So I thought let me keep it very to the point and basic.
So we would be going into details of all this in our subsequent lectures. Uh, I have how to diagnose
There's one
fibromyalgia.
question, Dr.
Madam,
Shashank, there's one question there.
yes, yes.
How to
From Dr.
diagnose?
Yes, from
Yeah.
Dr. Girish Vadgaonkar, how to diagnose fibromyalgia.
So fibromyalgia is basically you need to take a detailed history, and this will be a non-inflammatory pain. So patient would have a lot of aches and pains. I'm going only on the history basis. Everything hurts. They will be in immense pain, and they're actually in pain. Sometimes the family members get so fed up. Array, this patient looks so hell and hearty. She's so fine, and what is this pain every time? But actually, these patients, they have lot of pains and they're actually suffering. But when you go on examination, you will not find anything. But yes, you look for the tender points. Tender points, there are 10 tender points that you look for. And presence of tender points tells us that yes, this could be a tentative diagnosis of fibromyalgia. Of course, when we investigate it, we do the inflammatory markers, and these would be negative in these patients. They generally have some underlying stress. And fibromyalgia is something which is very difficult to treat. Um, you nearly need the help of a counselor, or if you can counsel the patient, there is nothing like it. They don't respond to treatment so easily, and they are always, mm, always they always feel that they have a major disease, and something is being overlooked in them. Rarely you can have patients of rheumatoid and lupus having symptoms of fibromyalgia, and over a period, I had a patient of classical fibromyalgia for a long time, and suddenly one day she came with joint swelling, and her anti-CCP was strongly positive. And then after starting the disease modifying anti-rheumatoid drug, her fibromyalgia has also subsided. So sometimes it could be a presenting symptom in patients of rheumatoid and lupus also.
Madam, we have one more question. How do we approach a patient who has complaints and history indicating Raynaud's, but when we see the patient, there is no visible finding?
Yeah, so no visible findings.
Probably of the Raynaud's. That is
So
what.
probably this could be related to the weather, bad winters and a severe cold, and the patient can be having, and if it remits on its own, then this could be a primary Raynaud's. In that case, we have to just manage the patient symptomatically. Patients of lupus can also have Raynaud's. Patients of scleroderma can have Raynaud's phenomena. Patients with mixed connective tissue, but all these would not have only Raynaud's as a presenting feature. They would have a lot of other symptoms and signs which would tell.
Maybe I'll just add something here. See, this is something which is quite common. Patients complain of Raynaud's, but when we see them in the clinic or the OPD, they don't have Raynaud's because it is something that is triggered by cold. So two things you can do. Maybe in the OPD itself, one is take a proper history. See if they give that proper triphasic history properly, and on exposure to cold, you are quite sure that this is Raynaud's. Second, if you still require clarity, if you are in doubt, ask them to keep a photograph whenever they have an episode. And thirdly, you can give them a cold object, ask them to wait in the OPD for 5 minutes, and then again come back to you. So these are, and if you have a AC chamber or something, there so many of them would come and show you. This is also common. Then there are patients with something called as palindromic rheumatism, wherein they would have pain and swelling in the joints. It is an episodic sort of a thing that lasts for, say, in a few patients it could be 2-3 hours. In a few patients it could be 2-3 days. When they come to the OPD, there is nothing. When you see their joints, there is nothing. So in that case, what you can do is take the proper history. See, if it is not just pain, whether they could see the swelling in the joint apart from pain, whether they could see some redness. See, we are dark skinned, so many times the redness may not be seen, but the swelling, most of the times they'll appreciate. For joints like shoulder, if they say it's not just pain, I couldn't even lift my hand. I couldn't lift the hand at all. So that would indicate that there must have been some episode of inflammation in the joint that time. So history-wise, this helps. And second, you can always ask them to keep a photograph of whatever. Whenever they have an episode, ask them to keep a photograph. This is something that can help in practice.
Especially the inflammation would affect the joint mobility. So when it is affecting the joint mobility, then yes, this could be a palindromic. I mean, it could be a articular involvement, like a inflammation in the joint. And they can later on evolve into a full-blown rheumatoid, or you can have rheumatoid which is palindromic onset, and they do respond to the disease-modifying anti-rheumatoid drugs, but they require less medications as compared to a patient with classical rheumatoid arthritis.
Madam, one more question. Which criteria to follow for SLE, SLIC or ULAR?
I think SLE is a clinical diagnosis, and we should also know, besides going for the criteria, SLE evolves over a period of time. So sometimes you may not have all the clinical features or all the criteria fulfilled on day one. No, you can have some symptoms which can come, some involvement which can come over a period of time. So it's purely a clinical diagnosis. I think ULAR criteria is what we follow, but it is individual again.
Maybe I'll just add something. See, always understand there are two types of criteria. One is diagnostic criteria, and second is something that you will see as classification criteria. So many times, most of the criteria that are there in rheumatology are mainly classification criteria. Why are they there? See, whenever we have a trial, suppose there is a trial of lupus patients, we want a definitive lupus patient to enter the trial and not any other patient. So there are criteria which you will see as classification criteria. This is to ensure that patients enrolled in a trial should be definitively having lupus, not something else. So whatever criteria see are more mainly for that. They are classification criteria. They need not always be taken the way they are for making a definitive diagnosis. And secondly, most of the conditions also have something called as activity criteria. So SLEEK and all those are not really diagnostic. They are, there are many criteria which look at activity of lupus and damage related to lupus. So the
So
SLEEK
cell
and
die,
yes. So
yeah, and that's what the cell die is, because basically a activity related. The leak is again an activity related criteria.
so there is classification criteria, there is diagnostic criteria, there is activity criteria, and there are damage criteria.
Damage criteria.
So let's and
So when we go into SLE, we'll be taking all these aspects of each. So this was basically our general approach. Then as we go ahead and we take one disease at a time, we would go into the details of all these things.
Madam, what are the DDs for typical Marer rash after ruling out RA and SLE?
Typical Mahler rash.
After ruling out RA and SLE.
So then you can have overlap syndromes, you can have mixed connective tissue diseases having um, uh, coming as a Mahler rash along with other symptoms.
There's one question from Dr. Vadgaonkar, role of tofacitinib in RA. We would discuss that.
I think we'll discuss it with,
yes,
I read that question, but I thought we'll take it with RA when we go to management of rheumatoid.
Dr. Abhijit, I have taken note of your listing. Your suggestions are really good. We'll definitely look forward. I'll announce. I'll do something according to your suggestions and definitely let everybody know next time. Can we differentiate signs and symptoms of osteoporosis or osteopenia from a rheumatological disorder clinically?
See, osteoporosis is basically, the patients, generally patients with osteoporosis have acute backache only when they have a collapsed vertebra or they have a fracture. So osteoporosis per se would not have any symptoms and signs as such. But yes, patients can have a lot of fatigue. They're not able to stand for a long time. They need support every time. Suppose they're standing, after some time, they need to support their back. Or if they're standing in the kitchen after half an hour, they feel, no, I can't stand anymore and I need to sit down. And these are the things. So you don't have actual signs. Very rarely you can have patients complaining of decreased height, because of severe osteoporosis. But it comes into diagnosis only on investigations, and especially when we always look for the underlying history, like patients has been on steroids for a long time, or a postmenopausal patient, a patient of lupus who has received a lot of steroid. These are the patients where we would be looking for osteoporosis. I don't think there is any specific symptom or sign which will tell us. Osteopenia, osteoporosis is basically a diagnosis on investigation. We can only say, okay, we should look for osteoporosis. But Shashank, what is your say?
Yeah, exactly as you said. This is more of a sort of investigation-based diagnosis. One of the most important things to remember from a clinical point of view is osteoporosis and osteopenia are painless conditions. So many times,
Exactly.
so many times we come across patients who have diffuse body ache, and a DEXA is there and osteoporosis is blamed for that pain. So always remember, osteopenia, osteoporosis, both are absolutely painless conditions unless there is a fracture. The moment you have a fracture, only then they will become visible or evident clinically. Till then, they are absolutely silent. They will be picked up only on investigation. Some investigation are there, either an X-ray or MRI or something else that will pick it up. Can still Kritan can still be there. SLE with we'll have a look at your this thing question in detail in SLE. This thing, Kritan, can one have SLE with negative ANA dsDNA? I think
I think
we'll
we'll
have
take
a
it
look
when
at
we
this.
come to the disease, individual
Rheumatoid.
diseases.
Yes.
No, we'll take all these questions.
Recommended book for reading rheumatology. Maybe we'll try, and there are quite a few books, but I think I'll just speak to everybody in the group and maybe suggest
We have a
one group
textbook
to
of
all of you.
rheumatology by our Indian authors also.
Indian Rheumatology Association. There's a textbook of rheumatology.
So there's a textbook of rheumatology, a very concise one written by our Indian authors. Then there's a book on rheumatology by Dr. Rohini Handa. So there are quite a few Indian books also, because we have Kelly's textbook of rheumatology. These books are there, but I think basics.
Madam, when to suspect MCTD clinically?
So a patient of MCTD, mixed connective tissue disease is where there is a combination of either symptoms of lupus, rheumatoid, polymyositis, and scleroderma. So you would have symptoms of all these, coming together in a patient. So patient coming with tightening of skin, joint pains, fever, hair loss, mouth ulcers, Raynaud's phenomena. This is a time when we would suspect a mixed connective tissue disease. And this goes on for quite some time. This is not an acute onset. This will go on for months to years before a patient actually reaches a rheumatologist. It's a multiple involvement.
Next session is going to be 2 weeks. So this is going to be every 2 weeks, second and the fourth Sunday, 11 a.m. is the fixed time. We would be updating everybody in the common WhatsApp group as well. The next session would be on examination. We have looked at the history taking. Now we would be looking at examination, and we are going to have a lot of videos. That is going to be absolutely practical sort of a session next time. So we are going to have a lot of videos as to how to exactly examine a patient with rheumatological history or some condition. And the next session is going to be, I would be taking it, would be approach to a patient with body ache and multiple joint pain. And again, that would be having a lot of photos and videos. So we are trying to make it as practical as possible. Girish Vadgaonkar, I would definitely add you to the group. So maybe if I have to summarize, whenever we see a patient with rheumatological complaints, believe me, in rheumatology, it is the history and examination that takes you really close to a diagnosis. And investigations are only going to support your final diagnosis in most of the cases. There will be only a few cases wherein that investigations will change everything. But most of the time, it is your plain simple history taking and examination that will give you. Whenever we look at rheumatology, we are looking at whether it is articular, non-articular, inflammatory, non-inflammatory, and then going on to acute, chronic, and the various subtypes. We'll definitely look at this when we are looking at a detailed approach 2 weeks from now. So do join us 2 weeks from now. We would have a session by Dr. Neena Chitnis on examination in rheumatology, and it would be full of a lot of photos and videos. So it will not be just a text-based lecture. We would actually have absolutely practical, hands-on sort of an approach to that. Thank you very much. Let's join again after 2 weeks.
One request from my side. One is,
Yes,
I'm
ma'am.
extremely sorry. There's been some road work going on here, and that's why the Wi-Fi was creating a lot of problem, and then there was a little disturbance in my slide presentation. Secondly, I would request all head of the departments to ensure that their postgraduates attend these sessions. It'll be really helpful to the students, and we did not get this kind of teaching when we were doing our medicine. So I would personally request everyone see to it that most of your postgraduate students should attend these sessions. As time goes and we take one disease, it will really help them and to approach patients in rheumatology. Thank you.
Thank you very much. We close the session for the day, and let's meet again after 2 weeks. Thank you all. Thank you very much.